We have discussed about the connective tissue disorder, that is the Sjogren syndrome. In the Sjogren syndrome, remember again this is more common in females than the male. So that is again 9:1. So it is again multi-system autoimmune inflammatory connective disorders and the middle age females like 40 to 60 year. And remember that Sjogren syndrome, it is the second most common connective tissue disorder. We would be having the primary Sjogren and the secondary Sjogren. Primary Sjogren, it is not associated with any connective tissue disorder, and secondary means Sjogren is what that association would be present. The major association with the rheumatoid arthritis. Okay, you have to remember this, that which connective tissue disorder is associated with the Sjogren syndrome, so that is the rheumatoid arthritis. Then based on the pathology, we would be having the glandular and we would be having the extraglandular. The glandular, it is for 50% and the extraglandular is again 50%. What are the clinical hallmark? You will see the patient would be having the dry eye, the dry mouth, keratoconjunctive. Dry eye means that the keratoconjunctivitis sicca, and we would dry mouth means that is the xerostomia. देखो xerostomia, that is a become its more specific feature. It is the more specific. The dry eye, it is not a more specific. Okay, so that you have to remember. And remember that the single endocrine gland involves you, that you have to remember one endocrine gland that is involved in the Sjogren syndrome, that is known as the thyroid gland. That is known as the thyroid gland. Then if we talk about the pathogenesis again, I told you already that if any autoimmune condition, in any autoimmune condition, remember there will be the two factors would be there. One, we would be having the environmental factors, another we would be having that is known as the genetic factor. In these environmental and the genetic factors, there would be the autoantibody formation. There would be the autoantibody formation. When there will be the autoantibody formation, there will be the autolymphocytic exocrineopathy. देखो dry eye, dry mouth, it means the secretion is affected, and for the secretion we have one gland that is known as the exocrine gland. So there is autoimmune lymphocytic exocrineopathy, means exocrine gland would be having problem. So there will be the activation of the ductal epithelium. When there will be the autoantibody will be formed against this activated ductal epithelium, of course there will be the blockage of the secretion, and if there is a no secretion would be there, that patients will end up with dry eye, dry mouth, dry skin, dry throat, dry vagina, everything will become dry, because we don't have what, we don't have the exocrine secretion in our exocrine secretions. Like we would be having the sweat gland, we have the sebaceous gland, we have the mammary gland. They all are what, they are the all are the exocrine gland, and we know that we would be having the secretion of all these glands. Okay. Then we would be having the genetic factors. If we talk about the genetic factors, we will be having one gene, that is the HLA-DR3. And remember that HLA-DR3 is also associated with one disorder that is known as the SLE, that is the systemic lupus erythematosus. Okay. And also we would be having, like there is a T cells would be there, and the test for the dry eye, I told you that screamer test. The test for the dry is known as the screamer test. Okay. Then there is a one more antibodies are there that you have to remember, that is the anti-Rho or anti-La. This is what, that is the positive in Sjogren syndrome. This is the positive in Sjogren syndrome. This is the positive in Sjogren syndrome. Okay, that you have to remember. So remember that anti-Rho or anti-Lo, this is the positive in what, in Sjogren syndrome. So this was about the Sjogren. Then we would be having the next connective tissue disorder, that is the systemic lupus erythematosus. Systemic lupus erythematosus, it is again multi-system autoimmune connective tissue disorders, and it is what, it is the type 3 hypersensitivity reaction. What you will see in the systemic lupus erythematosus, this is the disease of the woman in the reproductive age groups, like the female are the again more prominent than the male. Then we have discussed the risk factors. Again we would be having some genetic factors and environmental factors, and we would be having the immunological factors as well. Genetic factors we would be having that the HLA-DR3 genes would be defect, and we will see the complement deficiency as well. The environmental factors like the ultraviolet rays or the drugs that will be cause the SLE. Immunological factors like the increased activation of the B cell and the T cells. And the criteria, remember, for you have to remember in SLE, that is the SLIS criteria is for which condition? That is for the SLE. The in which you will see the more than 4 criteria would be there, at least one clinical and one laboratory criteria would be there. Again, just remember the name of that SLIS criteria. If the SLIS criteria is there, that is for the SLE. Then with the stand alone criteria, the stand alone criteria you will see the anti-nuclear antibody, or you will see the anti-double stranded DNA antibody along with the biopsy proven lupus nephritis. Lupus nephritis, it is 100% you will see in the childhood, and around 50 to 60% you will see in case of the adult. If the SLE is there, in a SLE there is a kidney involvement is there, so it will be the 100% that childhood you will see the lupus nephritis. But if it is the case of the adult, in adult you will see around 50 to 60% lupus nephritis cases. Then remember that standalone criteria, if you see the ANA and anti-double stranded DNA antibody, it means these antibodies are very important for the SLE. Then we have the organ involvement. Remember, we have the non-specific, that is the fever, weight loss, the fatigue, or the non-specific clinical feature that you will see in the systemic lupus erythematosus. If you will see the involvement of the oral cavity, in the oral cavity you will see the painless apathous ulcer would be there. In the joints you will see the non-erosive arthritis. We know that we would be having the osteoarthritis, rheumatoid arthritis, in which we see there is a cartilage degeneration. So arthritis that will seen in case of the osteoarthritis, so that will be the erosive arthritis. But in case of the SLE, we would be having the non-erosive arthritis, and the no deformities would be there because there is a no cartilage degeneration. We have discussed that the skin would be involved. The skin would be involved, that the photosensitive malar rash or the butterfly rash you will see, or the discoid rash would be there. Then you will see the lungs. In the lungs there will be the pleuritis, that is the most common, more than the interstitial fibrosis. Then we will see the cardiac. The cardiac you will see the pericarditis. The spleen you will see the onion skin appearance in the splenic tissue. Kidney also involved, that will cause the diffuse proliferative kidney. The diffuse proliferative kidney, it is example of the type 4 glomerulonephritis, in which you will see the subendothelial immune complex deposition, means below the endothelial you will see endothelial cells, you would be having the deposition of the immune complex, and that will become the wire loop kidney. So wire loop kidney, again this is the feature of what? SLE, butterfly rash, so malar rash, wire loop kidney, lupus nephritis. So all these are the very important keywords for the SLE that you have to remember. And also you will see the houseful phenomena. Houseful phenomena means you will see all type of the immunoglobulins, complements, everything will be at the single place. So that's will call the houseful phenomena. These two antibodies, again very important one, that the anti-nuclear antibody, that is the most sensitive for the diagnosis of the SLE. Anti-double stranded DNA antibody or anti-Smith antibody, that is the most specific for the diagnosis of the SLE. And also remember the anti-Rho or anti-La is also positive in case of the SLE. The anti-Rho and anti-La, this is also positive for SLE. So this is the positive for both Sjogren syndrome as well as SLE. So that is seen in the both condition, the anti-Rho and anti-La antibody. So this is what we having about that is the systemic lupus erythematosus. This is the very important antibodies, that is the anti-nuclear antibody, most sensitive, anti-double stranded DNA anti-Smith antibody, that is the most specific antibody, and anti-Rho anti-La antibody, that is the positive for the SLE, they are the non-specific. Okay, so this question we have already discussed. Then we was discussing systemic lupus erythematosus. So this is what we have discussed about the connective tissue disorders. We have discussed about the rheumatoid arthritis, Sjogren syndrome, and we would be having the systemic lupus erythematosus. Then the next question, if we say that the patient age 40 has been ill during the approximately 8 years, complained of the pain in the lumbar part of the spine. So you see there is a pain in the lumbar part of the spine on physical exercise. In cervical and thoracic part, especially when coughing, pain in the hip and the knee joints on the right. On examination, you see the body is fixed in the forward inclination with the head down. Gluteal muscles atrophy, you will see the spine röntgenography. What is the meaning of the röntgenography? The röntgenography means X-ray. Okay, this is the old terminology of the X-ray, that is the röntgenography, who discovered the X-ray. So that is what, that is meaning of the X-ray. Ribs osteoporosis, you see the longitudinal ligament ossification. So what is the most likely diagnosis? So you have seen that the patient has, there is pain in the lumbar part. If the lumbar part is affected or the spine, that means this is the most probably that the ankylosing spondylitis would be there. So let's discuss about the ankylosing spondylitis in details. This is again very important features. You will get the question about the ankylosing spondylitis, spondylolisthesis, spondylosis, spondylitis, spondylitis, psoriatic spondylitis. So everything we will discuss in detail now. So see, first we are going for the spondylolisthesis. So first let's discuss what the spondylolisthesis. This is the note about the rheumatology topic basically. This is integrated with the orthopedics. So in ortho, if we say the spondylolisthesis, if we see the spondylolisthesis, it means there is a one slipping of one vertebra over the another vertebra. We know that we have the 26 vertebra. So if one vertebra will be slipped into the another, so that is known as the spondylolisthesis. So this is the slipping of one vertebra over another. So that is known as the spondylolisthesis. What is the cause of the spondylolisthesis? The cause is, remember, the cause is what? That is the trauma. Or we say called the fracture of trauma or the fracture of pars interarticularis. See, if you see any trauma, what is the meaning of the, I will tell you what is the trauma. Trauma will be there, the fracture. If any fracture will be there of the pars interarticularis. देखो, articular means there is a joint. The articular means joint. Inter means when between there is something, between the two parts. Like for example, if this is, there the two box are there. If I say the two box, if I say inside the box, we call this as the intra. If this is the anything inside, that is we call the intra. But if it is present, anything present in between these boxes, we call this as the inter. So it means, like for example, this is my one vertebra, this is my another vertebra, and between them we will see there is some this is what we call the interarticular. So that is the pars, means the interarticular part. If the trauma of the interarticular part would be there, that will lead to the slipping of one vertebra over the another vertebra. You will see some sign would be here, that is known as the beheaded Scottish terrier sign. Beheaded Scottish terrier sign. And that in which you will see the most common site that is affected in the spondylolisthesis. It is what? That is the L5S1. Okay, we are making just base for the ankylosing spondylitis, so no questions, or you will be understand the concept also. So beheaded Scottish terrier signs. This is the scene, that the like the sign that you will see in case of the spondylolisthesis, in which you will see there is a like the slipping of one vertebra over the another. There is a one more thing that is known as the spondylosis. So what is the meaning of the spondylosis? The spondylosis means that when the spine will be denatured. So this is known as the degeneration. This is known as the degeneration of the spine. degeneration of the spine. The examiner will always confuse you between the spondylosis, spondylitis, the spondylolisthesis. Now you understand what is the spondylolisthesis means, the slipping of one vertebra over another. Spondylosis, that means the degeneration of the spine, and this is most commonly that is seen in the elderly people. This is mostly seen in the elderly people. We would be having another one that is known as the spondylitis. That is the litis. देखो, whenever the itis would become, when the itis means there is some inflammation would be there. So this is what, that is the inflammation of the vertebra or the inflammation of the spondylum. Spondylum means basically vertebra. So that is the inflammation that will seen in case of the ankylosing spondylitis. AS means ankylosing spondylitis. We will discuss it later on. So this is what, that spondylosis or the spondylitis. You see the spondylitis, that is the inflammation. Okay, and in the spondylosis, remember the degeneration of the spine, and the most commonly that is affected is what, that is the L5, lumbar 5 vertebra. The lumbar 5 vertebra is the most commonly affected. So they again come back to the spondylolisthesis. There is the beheaded Scottish Terrier sign. What the clinical feature, if we say, the clinical feature we will see in this patient, that is the back pain. The clinical feature that we will see in this patient, that you will see the back pain that will radiating to the lower limb. The back pain radiating to lower limbs. Radiating to lower limb. Along with that, you will see the one sign would be there, that is known as the stap sign. That is known as the stap sign. Stap sign, when you will see on palpation of the spine, when you will try to palpate the spine, you will feel that somebody is stepping out. So that will be looks like the stap sign on the palpation of what, spine, on the palpation of the spine. So what we call this as the stap of over the spinous process. Stap of over the spinous process. So that is known as the stap sign. So what you have to remember here, the spondylolisthesis, what is the meaning of the spondylolisthesis, then you have to remember what the cause is here, then remember the stap sign. This just remember the name, that is the stap sign, and the back pain of course would be there, that will be radiate to the lower limb. Okay, that is that you can do. After that, if we will come back to our main topic, that is the ankylosing spondylitis. That is the ankylosing spondylitis. Ankylosing spondylitis. देखो, ankylosing spondylitis is also what we have discussed, the rheumatoid arthritis, we have discussed the Sjogren syndrome, SLE, osteoarthritis. All these are what? These are all are the autoimmune condition. They all are the autoimmune condition. The ankylosing spondylitis is also what? It is also the autoimmune condition. It is also the autoimmune condition. But if I ask you, tell me, most of the autoimmune condition, they involve the females, or they are common in females more than the males. Most of the autoimmune conditions, they are common in females more than the males. Tell me one autoimmune conditions which is more common in males than the female. So that will be our ankylosing spondylitis. Okay, so this is what, that the autoimmune condition that is common in males, that is common in the males more than the females. But most of the, if you see the autoimmune condition, the autoimmune condition that will be common in the females. Okay, the cause is idiopathic. So most of the, but actually the most, if you'll see, and the ratio would be also very much higher, like you have discussed in the Sjogren syndrome, SLE, the ratio was 9:1. So it means that that is very common. But one autoimmune condition that is more common in the male, that is the ankylosing spondylitis, and basically more in the young patients, more in the young patient. It is what? It is the HLA B27 positive. So the HLA-B27 positive, and they are the rheumatoid factor negative. These are the rheumatoid factor negative. So if in the question they will mark you the seropositive, it means they wanted to talk about the rheumatoid arthritis. But if they mention in the question seronegative, means they wanted to talk about the ankylosing spondylitis. What the pathology we will see in ankylosing spondylitis? The pathology, always remember, there would be the attachment of the tendon or ligament to the bones. What you will see the pathology? You will see there will be the attachment of tendon or ligament. What is the meaning of the tendon? What is the meaning of the ligament? Can anyone tell me? देखो, they are the simple. If we want to connect the bone to the bone, which structure would be there? That is the tendon. And if you want to connect the bone to the muscles, that is structure is known as the ligament. The structure that connect the bone to the muscles, that is known as the ligament. The structure that connect the bones to the bones, bone to bones, that is known as the tendon. Okay, so if you'll see the attachment of the tendon or ligament to the bones, that will seen in case of the ankylosing spondylitis. What the clinical feature we will see in the ankylosing spondylitis? The clinical feature that you will see is the sacroiliitis. That is the sacroiliitis. Means there will be the inflammation of what? Iliitis. The inflammation of what? Sacrum. The inflammation of the sacrum would be there. Then you will see the morning stiffness. Morning stiffness would be there. The morning stiffness would be there. Morning stiffness means that because what happened? The inflammatory exudate, that the inflammatory, because we have discussed now, this is the what? This is the HLA-B20, and it is the autoimmune inflammatory condition. So whatever the inflammatory exudate would be there, that will be collected at the night and will be deposited in the joints. And when this will be deposited in the joint, the patient will feel the morning stiffness. Okay, when the person will try to do some activity, so it will keep improving with the activity. So patient will come with the this kind of the scenario that Dr. Shah, I have problem with the morning, I have the morning stiffness, like whenever I start working, my all the problems resolves or the improves with the little bit activity. When I am doing some household works, when I making the tea, so it means when I am doing some activities, my condition has been improved. So that is what we understand, that this patient having what? Morning stiffness. The morning stiffness we have discussed till now in the two conditions, ankylosing spondylitis and in the rheumatoid arthritis. Ankylosing spondylitis and the rheumatoid arthritis. So morning stiffness, remember, you will see the inflammatory exudate. There would be the inflammatory exudate will be collect at night, and it will improves with activity. It will be improves with activity. Now, if you ask what is the association with the anterior uveitis, the associated with the one condition called the anterior uveitis. This is known as anterior uveitis. There's ankylosing spondylitis. It is associated with one condition called the anterior uveitis. Okay, so they are associated with one condition that is known as the anterior uveitis. So this question has been there, like if the question in the question they will give you in the options like about that in the question they will mention about some keywords about the uvea, or they just like they will say that the patient has the inflammation of the middle layer of the eye. The middle layer of the eye is what? That is the uvea. The inflammation of the middle layer of eye. So you have to understand that this patient, and after that this patient has got the morning stiffness and the other clinical feature of the other clinical feature of ankylosing spondylitis will come. So it means you have to understand that they wanted to talk about the conditions that is known as ankylosing spondylitis, the inflammation of the middle layer of uvea. I, that is known as the uvea, and that is known as the uveitis. The inflammation is known as the uveitis. Then other important thing that you have to remember in the ankylosing spondylitis about the röntgenography, means about the X-ray. So the X-ray, that is the, because most of the things you will able to understand that you will get the questions about the radiological findings, because this is a very common that you will seen in the ankylosing spondylitis. Whenever the spine problem will become, you will ask the patient for the X-ray. So you will see the radiological feature, the radial physical features, or you can go for the CT scan also. So but most probably you will go for the X-ray. You will see the bamboo spine, you will see the bamboo spine, and the bamboo spine we call this is known as the we call the enthesitis. The enthesitis means there is a vertical syndesmoid fusions. It means that like all the spines or the vertebra, they will be fused, so it will be looks like the bamboo spine, it will be looks like the bamboo spines, it will be looks like the bamboo spine vertebra. So that will be very important point, that is the bamboo spine. This is the feature of which condition, that is ankylosing spondylitis. So what you will see here, there will be the vertical syndesmosides fusion, vertical syndesmosides desmophytes fusion. Then you will see also see the trolley track sign. You will see the trolley track sign would be there, and also we call this is known as the dagger sign. We also call this is known as the dagger sign, and this is occurs due to which conditions? Due to this is occurred due to calcification of the calcification of ligaments. This is occurred due to calcification of ligament. So that is the trolley track sign. So let's see here. There is a one more thing, that is known as the DISS, that is the DIS. So DIS means H means that is the diffuse idiopathic skeletal hyperostosis. Okay, this is also known as the Forstier disease. This is also known as the Forstier disease, in which what you will see the ossification of the, if you want to write it, this is very high yield, so don't write it, just see it only. Ossification of the anterior longitudinal ligament. Why I am writing, I will tell you. Ossification of the anterior longitudinal ligament. So this is known as the DIS, that is the diffuse idiopathic skeletal hyperostosis. Because if there is a ossification of the anterior longitudinal ligament, so again this is the known as the DIS. And there is if the ossification of the ossification of the posterior longitudinal ligament is also there, and this is most commonly seen in the elderly people only. The most commonly this is seen in the elderly peoples. Like here, if you want to see here, we can see there's a longitudinal ligament ossification. The longitudinal ligament ossifications would be there. So that again I have, that's why I wrote here. So here this is longitudinal ligament ossification that will seen in the ankylosing spondylitis, but we'll giving the different term here, that is another diffuse idiopathic skeletal hyperostosis, or we would be having the ossification of the posterior longitudinal ligament, that is known as the OPAL. Ossification of the posterior longitudinal ligament, again that will be seen in the elderly people only. Now if you wanted to see in the question, there is a pain in the lumbar part of the spine on the physical exercise, in cervical and the thoracic part, especially when the cuffing, pain in the hip and the knee joints on the right. So pain can be spread from spine to the lower limb. Okay, and to the hip regions, to the knee joint regions. On examination, you see the body is fixed in the forward inclination with the head down, means the head, it is the bowing down. That gluteal muscles atrophy, the spine x-ray, you see the ribs osteoporosis, longitudinal ligament ossifications. So these are the most likely diagnosis of what? That is the ankylosing spondyloarthritis, or we call the HLA, which positive HLA B27 positive sero negative. That is the sero negative arthritis. Okay, is that clear? Here, if you talk about here, like in the question, they have mentioned that body is fixed in the forward inclination with the head down. So what we called here, this is known as the scoliosis. This is known as the scoliosis. Whenever you see the let any deviation of the spine by any degree of the from the central axis, so that is known as the scoliosis. That is known as the scoliosis. So let's discuss about little bit about the scoliosis here. If I hope every one of you have studied about the scoliosis, and if you have not studied, definitely the in your subject the internal medicines, so they were going to ask you about that, about the scoliosis, kyphosis, lordosis, and so they all are the scoliosis position. What is the scoliosis basically? In scoliosis, you will see the lateral deviation. You will see the lateral deviations of spine. The lateral deviation of spine by at least minimum 10 degree from central axis. So that is known as the scoliosis. That is known as the scoliosis. Okay, देखो, there is a two curvatures would be there. When we talk about the spine, in the spine we would be having the two curvature. The one curvature, the primary, is known as, that is the large curve would be there. That will be the large curve would be there. And this is known as the primary curve. Then we would be having the two secondary curves would be there. The two secondary curves. So it will be looks like this. So this is what, that is the basically it like this. So this is the S shape. So this will become the here, that is the primary curvature, and the primary curvature, this is become the, this is the largest curves, and above and below that we would be having the, that is known as the secondary curve. So that is known as the secondary curve. Okay, then here remember that in the scoliosis we would be having, there is the one test will be done, that is the Adam forward bending test. We will done for the like for the structural and the non-structural scoliosis, but again that is the no need to remember that. Just scoliosis we remember, we would be having the, like if we would be having the lordosis, what you will see, the lordosis, like the person, when the person will be bending back, and we would be having the kyphosis, we would be having the kyphosis. The kyphosis, what you will see, the patient will be the bending forward. It's not, you write here inclining back, inclining back, and if the patient is bending forward, that is the kyphosis. In lordosis, remember, the lumbar vertebra basically would be affected, or the lumbar curvature would be affected, lumbar vertebra would be affected, and in the kyphosis, remember, there would be the thoracic vertebra would be affected, thoracic vertebra would be affected in case of the kyphosis. Like if the asthma patient is there, then the asthma patient basically you will see the kyphosis, the patient would be in the, like the forward bending forward position, so that is again the kyphosis position. So this is what the thoracic vertebra would be affected, and remember which ligament would be affected here, that is the posterior longitudinal ligament would be affected, posterior longitudinal ligament would be affected in case of kyphosis. And in case of the lordosis, you remember, there would be the anterior longitudinal ligament would be affected, anterior longitudinal ligament would be affected. So there are two conditions. The one we would be having the lordosis, another we would be having the kyphosis. In the lordosis, the person will be inclining back like in the position of the Jesus Lord. You know the Jesus Christian. So that is the Jesus. The Jesus is, remember, that is the in the position of the lordosis positions. And the kyphosis, remember, the patient will be bending forward. So and the thoracic vertebra would be affected, and which ligament would be involved? Posterior longitudinal ligament would be involved. Posterior longitudinal ligament would be involved. Okay, is that clear till now? So let's take a little break of 10 minutes and then we are going to continue. Okay, so here let's take a 10-minute break and then we will see you within the after the 10 minutes. So here the about the next one is what, that is the tuberculosis. So what is the tuberculous spondylitis? So here we would be having the tuberculosis of the bones, tuberculosis of bones and joints. So the tuberculosis it is caused by, you know, that the bacteria that is causing the tuberculosis, that is the Mycobacterium tuberculosis. So that we have discussed in that you have studied in your third year also. The Mycobacterium tuberculosis that cause what? That is the tuberculosis. So this tuberculosis of the bones and the joints, this is also known as caries or Koch disease. It's also known as the caries or Koch disease. And it is the less severe local manifestation. If you want to compare it with the normal pyogenic bacteria, it becomes the less severe. But while if we talk about the other pyogenic bacteria that causing the like the pus formations or the suppurative inflammations, that it will be like with comparison with them, it will become the less severe. It is the less severe, and of course there will be the local manifestation would be seen. If we talk about the organs, remember the organ that is involved here, that is the organism, that is the or the cause of the tuberculosis. So remember the cause of the tuberculosis is what, that is the Mycobacterium tuberculosis. Mycobacterium tuberculosis. And how they will spread? They spread through the hematogenous routes, means through the bloods. They spread through the hematogenous route. They spread through the hematogenous routes. And remember that the from primary source. The primary source is what? The primary source is of course thus like human beings would be there, like that it will becomes in contact with the with person to person. So it will be the airborne disorders, like when the Mycobacterium tuberculosis will go to the will come in the contact with the air, so that the polluted air will becomes in another contact with another persons, and then will be it will enter in our body, and through our body it will go to the hematogenous routes, and then it will be settled down here in our bones, in the joints, in extra maybe lymph nodes. So that will become the extra manifestations or the extra pulmonary tuberculosis. And if is the most common site, if I say the most common site of the tuberculosis is what? Can anyone tell me what is the most common site of the tuberculosis? Of course, that is the lungs. So most common site, if say in the body, in the body, in our whole body, the most common site is the lungs. If we talk about the musculoskeletal system, if we talk about the musculoskeletal system, in the musculoskeletal system, remember the most common site of Mycobacterium tuberculosis, that is the spine. And if it is present in the spine, we call this is known as the TB spondylitis. We call this the TB spondylitis. After the spine, there would be the like the hip, and there would be the knee. So this will be the our musculoskeletal system. This would be our musculoskeletal system. If we talk about in the spine, remember this is the most common is what in the spine, that is the dorsolumbar. The most common in the spine, that is the dorsolumbar would be there. Then there would be the dorsal, and then it will be the lumbar side. And if you talk about the children's, like in the children, we would be having the cervical spine, the TB. In children, we would be having the cervical spine TB. Cervical spine TB, that will be the that is the cervical spine TB would be there. That is the most common in children. If we talk about the like the there is some variants of the TB also, like we would be having the caries sika. Like if we talk about the TB in the shoulder, that is the given the particular name, that is the caries sika, and the TB of the fingers is also there, that will give the spine ventosa. But again, that is just remember the name, spine ventosa is there, caries sika would be there. So there are some different variants of the TB. The main thing here you have to remember here, that is the most common site in the TB, most common site in our whole body, that is the lungs. In musculoskeletal system, it is the spine, and if it is present mycobacterium tuberculosis, it is present in the spine. We call this condition as the TB spondylitis. And in children, remember this is known as the cervical spine. The cervical spine, it is the most common in the site in the children. Here we are going to discuss about the TB spondylitis. That is the another name of the TB spondylitis, that is known as the port stitches. Okay, so that is what we have to remember here. The TB of the spine, or we call this as the TB spondylitis or the tuberculous spondylitis. And another name of this one is known as the port stitches. This is known as the port disease or the port spine. The ports disease or the port spine would be there. What you will see in this condition, there will be the whenever there will be the TB, like the TB spondylitis would be there. So of course there will be some granular tissue would be there, and these granular tissue will try to compress that spinal cord. It will try to compression on the spinal cord. And when there will be the compression on the spinal cord, so what will happen, there will be of course neurological manifestation would be there. There will be the neurological manifestations would be seen. The neurological manifestation would be seen. And whenever there will be the neurological manifestation, we call this condition as the Port's paraplegia. Means there are high chances that if the spine, of course the spinal cord is injured, if the spinal cord is injured, then these patients can have lead to the paralysis. So we call this as the Port's paraplegia. And the cause, remember the cause for this condition is always there will be the mechanical cause. What the causes would be there? The causes we will see here, that is the mechanical cause. And the mechanical cause, remember what you will see, this is due to granulation tissue. Due to granulation tissue. When the granular tissues would be there, like the TB tissues would be there, so that will be growing, that will try to compress what, that will try to compress the spinal cord. And there will be like if the inflammation, we know that in the tuberculosis we would be having some cord factors would be there. So if there is a cord inflammation would be there, and the cord inflammation, that will again we call this the cord edema. So that will also lead to the what, paralysis, because that will also lead to the compression of the nerves. And if we would be having the thrombosis of the spinal artery, like we know that there is just some spinal artery would be there, but if they will see the thrombosis formation would be there in the spinal artery, that again will lead to the, of course, if the thrombosis, what will happen, there will be the ischemia of the spinal cord. There will be the ischemia. Whenever any vessel would be there, and in this vessel, if we see, there would be the some thrombus formation would be there. There will be some thrombus formation would be there. And if the thrombus formation would be there, there is the decrease in the oxygen, and the decrease in the oxygen is known as the ischemia. So there will be the ischemia of what? Spinal cord, and that will lead to the, if the ischemia of the spinal cord, there will the rapid onset paraplegia would be there. So what are the causes of the paraplegia? The mechanical, the cord edema would be there, or the thrombosis of the spinal artery. You understand why there will be the compression on the spinal cord? Because of some mechanical compression. So that is the neurological manifestation would be there. What is the most common site of the TB spine? The most common is what? That is the paradiscal. The most common is what? That is the paradiscal. Paradiscal means, like for example, if this is my vertebra and we have central axis, so on the on the disc, in the discs, like the paradiscal intervertebral disc will be there. So around the intervertebral disc you will see the paradiscal. Okay, so that will be the most commonly that is affected in case of the port spine or the TB spine. Okay, is that clear? So that is what you have to remember here, that if the mycobacterium tuberculi, it involving the bones, so in the bones we would be having it involving the spine, we call this as the TB spondylitis. We call this as the TB spondylitis. Okay, or another name of this condition is now port spine. Sometimes they will give the port spine also. So remember, the both is very important. So here what we would be having? We would be having the tuberculous spondylitis. Then the next one we would be having, that is the psoriatic spondyloarthropathy. देखो, psoriatic spondyloarthropathy, of course due to psoriasis. It is occurs due to psoriasis. So whenever we will discuss about the psoriasis, then we will discuss little bit about the spondylitis. Like the same things, like when the psoriasis, the involving the joints and the vertebra, so that will lead to the psoriatic spondyloarthropathy or the psoriatic spondyloarthritis. Okay, and there is a spondyloarthropathy on the background of the Rita's disease. देखो, Rita's disease is what? That is the exam. That is what? That is the reactive arthritis. So let's see some question here first. A question: a 18-year-old patient complained of the pain in the knee and the ankle joint. Temperature elevation up to, there is a knee and the ankle joint pain are there, means there is arthritis are there, arthralgia would be there. He had a respiratory disease 1.5 years back. Examination you see temperature 38, there is a pulse is there, rhythmic, AP blood pressure is down, heart borders without changes, sounds are weakened, soft systolic apical murmur. देखो, there will be the apical means that the apex. In apex we would be having the, what we would be having at the apex? We having the mitral wall. We would be having the mitral wall would be there. The mitral wall, that is bicuspid wall present on the left side. So we know there is a soft systolic apical murmur. So at the apex we are hearing the soft systolic. So it means this is a case of, this is due to mitral stenosis, and the mitral stenosis we see in which condition? In case of acute rheumatic fever. So what indicator is connected with the possible etiology of the process? So we have discussed this question. What are that? The anti-streptolysin O antibody would be connected with this etiology, with the acute rheumatic fever. Then after that, a man gout we have not discussed till now. Then this question: 40-year-old woman is ill with the rheumatic disease. So rheumatic disease is there, composite mitral disease with the prevalence of the stenosis. Complaint of the palpitation. So this, they are saying that the patient having the rheumatic disease, with that we would be seeing that the patient having the mitral stenosis would be there. Complaint of the palpitation, fatigability, progressing dyspnea, attack of the dyspnea and the hemoptysis. Now she cannot be engaged even in the easy activity. What tactic is the most expedient? So this is what? That is the mitral commissostomia. Means there is a involvement of what? Mitral valves. The commissostomia means that is the valves basically. So it means there is a, what tactic is the most expedient? The involvement of what? Mitral valve would be there, and the mitral stenosis would be there. Here the mitral disease. In the question itself they have written everything. and they are asking what tactic is the most expedient. So that is the mitral commissurotomia. Okay, let's further discuss about the reactive arthritis also. Okay, this will be last for today. So what we have, that is the reactive arthritis. See, whenever there will be the any joint pain would be there, the swelling would be there, that will the triggered like by any infections. Okay, like for example, if I having the streptococcus bacteria, that to the salmonella bacteria, so that will be causing some kind of pain and the swelling. Okay, that bacteria is in my body, and after that if you are seeing the some joint pain would be there, the joint swelling would be there, so that is mean they are what, they are migrating to my joint, they are migrating to my swelling area, to the joint area, and they're causing the pain and the inflammations. So this bacteria is what causing the pain and inflammation in the joint. So that means this bacteria become causing the arthritis. And how that will become, they will become reactive, they are become the reactive. So that is known as the reactive arthritis. This is the name is saying the reactive, so means something is reactive. So what are reactive? The some bacteria can be there. For example, like if I saying, if I say that this is the joint pain and swelling, the joint pain and swelling triggered by any infection in any another part, in another part of the body, another part of the body, another part of body. So that is known as the reactive arthritis. That is known as what? That is known as the reactive arthritis. So arthritis, what, that is the, like the, we would be having the joint inflammations, and it will occur following the bacterial infection, occurs following bacterial infection. So that we call the reactive arthritis. In initial days, like before, earlier the reactive arthritis, this is also called as Ritter's syndrome. This is also known as the, this is aka means also known as, this is also known as the Ritter's syndrome. This is also known as the Ritter's syndrome. Okay, now if we talk about the epidemiology, so this is like the very less common. Like you see the around 20 to 30 patient would be there in the population of 1 lakh populations. So that's why it become very common, very less common, and this is the more common in the male than the female, and more likely to occur into second to third decade, second to third decade. And this Ritter syndrome is also associated with, it is also associated with one HLA-B27, HLA-B27 gene, but they are not 100% they are associated. They are like 30 to 50% they are associated with HLA-B27. They are associated 30 to 50% they are associated with HLA-B27. What are the causes? The causes, remember, that is again very important. The causes, remember, they are the like the streptococcus bacteria, the streptococcus. So they are associated with the streptococcus bacteria. They are associated with one sexually transmitted bacteria, that is known as the chlamydia. That is known as the chlamydia. And this is become very important because this question has been asked loads of the times, and most of the times the question has been asked from the chlamydia only. देखो, chlamydia, it is a sexually transmitted disease, so they will connect the sexually transmitted disease, and they will give you given in the question some history about the this chlamydia and the sexually transmitted disease, and after that they will tell this some arthritis problem would be there. So it means that they wanted to talk about the Ritter's syndrome or the Ritter's disease or the reactive arthritis. So this is the chlamydia trachomatis, chlamydia trachomatis. So chlamydia trachomatis causing the sexually transmitted disease. What other things like the salmonella can also cause the Reuters syndrome. The Shigella can also cause the Campylobacter jejuni, Campylobacter jejuni. They can also cause the Reuters syndrome, or we can also having the Yersinia also. Okay, all these can cause the what Reuters syndrome or the reactive arthritis. What is the pathophysiology behind this reactive arthritis? So remember that they are what they are the immune mediative conditions. They are the immune mediators. If we talk about the causes here, the etiology or the pathophysiology. So remember that the etiology here, that is the immune mediated. This is the immune mediated condition. This is the immune mediated condition. This is the immune mediated condition. So in the immune mediated, of course, there will be the immune cell would be there. There would be the immune cell would be there. So in immune cell we would be having the T cells, and this immune T cell, they will be activated by the bacterial fragment. This activated by the bacterial fragment, because whenever like bacteria would be involved, so these bacteria will be enter in our body, they will activate these immune T cells, and mistakenly they will attack the component of the certain joints. So whenever these immune cell would be there, they activated by this bacterial fragment, and mistakenly what they will do, and mistakenly attack the component of like the certain joints would be there. So they will attack these joints problem, and that will lead to the arthritis, in this patient. So this patient will end up with the sudden onset the pain. There will, of course, this will be the sudden onset pain would be there, sudden onset pain, and it will be around 1 month duration would be there, and you will see there will be the asymmetric inflammation. There would be the asymmetric inflammation would be there, asymmetric inflammation. And the most common joint that will be involved here, that is the knee joint. The most common joint that is involved is the knee joint. The very important thing that you have to remember here about this condition is known as the Reuters syndrome. You will see one triad in Reuters. We call this is known as the Reuters syndrome triad. You will see one triad would be there, and this triad means that it is very important. What kind of the triad you will see? You will see that the patients can't these patients can't climb, can't climb, can't see, can't pee. Just remember this, and you will be able to understand about the Reuters syndrome. See, if you see the patient, about that patient is can't climb. The can't climb means that patient is having what? That is the arthritis. The patient would be having the arthritis would be there. If you see the patient can't see, the can't see means the patient having the conjunctivitis. The conjunctivitis. Can't pee means the patient would be having the urethritis. The patient would be having the urethritis. So if you see in the question, the arthritis, conjunctivitis, urethritis, it means they are talking about which condition? They are talking about the Reuters syndrome. Because in the Reuters syndromes, of course, the urethras, there is the inflammation of the urethra, there is the inflammation of the conjunctiva, and along with that the inflammation of the arthritis. देखो, these immune cell, we have seen that this is the immune mediated condition. So whatever the T cells would be there, that will be deposited in the conjunctiva, that will attack the urethra also, that will attack the arthritis also. So these patient will be land up with the can't climb, can't see, and can't pee. Other than that, you will see this patient would be having the dysuria also, the this patient would be having the dysuria, prostatitis, prostatitis, T A T I T I S, prostatitis, and this patient would be having the cervicitis, the inflammation of the cervix, the inflammation of the prostate. Then the patient will be having the pain while urination. So all these symptoms that you will see in the patient with the Ritter syndrome, and this is very important that you remember to see. The other important things in the Ritter syndrome or the reactive arthritis that you have to remember about, that there is a chlamydia trachomatis, because the most of the question that will become directly from the chlamydia only, chlamydia part. Okay, so the chlamydia trachomatis, and we would be having the Ritter syndrome, so that is again very important one. Okay, is this clear? So this is what that you have to remember. So this is about that what you will be called that is the reactive arthritis or the Ritter syndrome. So so this is all for today, and please do revise this, and tomorrow again we will meet. Tomorrow we will discuss about the gout, and I think scleroderma, there is topics scleroderma, and after that there is a dermatomyositis, one topic about the dermatomyositis. And thus some questions we will see, there will be the repeated questions now onwards, so that we will keep doing the questions after that. So please do revise this, and like you will be having the exams, so keep preparing for the exam. Whatever the topics we have discussed, the exam would be from there only, so that you will able to understand, or you able to pick up the questions, so that you will able to understand the question as well in depth. You understand like how type of the questions will be coming, and how you will able to solve them. Of course, that will be the, so all no questions will not be the easy one. That will be the mixed bag of everything. The easy, intermediate, and the hard questions would be there. I will make the question bank, and so see you tomorrow. Good night. And those who have not registered, you can kindly register for the paid classes. So see you tomorrow. Have a good day. Bye bye. Take care. If you have any
Bye,
question,
sir.
you
Thank
can
you, sir.
ask me.
Goodbye.
Good night. Good night. selfish, successful is the one who enjoys his daily routine. ले जाए जाने